Thank you everybody for joining us for our injury prevention, our winter series. We're kicking this one off. Just if you haven't joined our series before, we do seasonal injury prevention series. We're going to do, a spring, summer, fall. For those of you that are healthcare providers that like to be involved in this kind of teaching and education, you're welcome to reach out to us and see if there's something that you're interested in presenting on. We love to engage all of our healthcare providers in this and our community content experts. So today we have Geoff Frattalone and Polly Dacus. Dacus, am I going to say that right, Polly, all the time? These are two great nurses that have been working with the university for quite some time. So Polly has been with the university for 13 years. She worked in the emergency department. She's currently the nurse manager at the university Snowbird Clinic. She's been there since just November, kind of opened it up. So September, November, getting it opened up and running. She spent the last 14 years skiing, running, climbing, everything across the greater western states. And then she does have a fantastic little cute French bulldog who enjoys easy trail romps and hours of couch snuggles. And if you're friends with Polly and you see her pictures, they make me just be nervous sometimes because I can't do these things. I would end up as an ER patient. So it's been great. She worked as a charge nurse in the emergency department, working with traumas, and now we're really grateful that she's up there with the Snowbird Clinic and getting things going and combining her love of medicine and skiing. And then we have Geoff. So Geoff has also been an RN for 13 years. He spent time in our neurocritical care unit, our ICU, our emergency department, went to CVICU, and then AirMed. So a variety and plethora of experience there. He's also a TNCC instructor, critical care RN. And then I have also heard that he is quite the gazelle on skis is the correct term that I have heard multiple times. So I'm really grateful that both these guys are super passionate about skiing and that they have wanted to join us today. Disclosures, there's no disclosures on here that we need to tell you guys about as far as getting contact hours. So no disclosures by any of us. All right, so here's our full series, the 26th, February 9th, February 23rd, and March 9th. So again, like I talked about, these are a blast of 5 sessions across every other week. So getting those things down for our winter injury prevention series. So our next one is snowmobile safety on January 26th. Chris Holler is with our Department of Parks and Recreation. He has presented for us before on ATV safety. And then we're still working on getting some speakers together as well, but that'll be our next one. All right, contact hours. So we do offer nursing contact hours for this. You just need to participate in the end of presentation polling to get these nurse contact hours. That's good for nursing contact hours as well as EMT and paramedics. You can present this to your training officer and ask them if this qualifies as going towards some of the hours you need for recertification. So, all right. We're going to continue to. Next week, we have our trauma grand rounds. It is from 7 a.m. to 8 a.m. We're going to be hearing from Dr. Colonna. He's going to be talking about chest trauma and rib plating. And then our EMS grand rounds is February 10th. And that's going to be managing your TBI in a trauma patient. Trauma grand rounds is always the third Thursday of the month. And it's going to be on odd months from 7 a.m. to 8 a.m. And our EMS grand rounds are always the second Wednesday of even months from 2 to 3. So if you ever want to join those, and you're not already on our contact list, please let me know and we'll get you on that contact list. We always like to do a shout out of things that are great for the university. Crisis Standards of Care is a fantastic site. If you're not part of this, if you haven't signed up or downloaded their app, Annette is really proud of their app. So they've got some great offerings, educational offerings, great things on burn, hypothermia, something we're going to talk about today, things like that. So go ahead and check out that site. We're also continuing our intimate partner violence series, our primary prevention. We're going to be doing 3-hour symposiums every the last Tuesday of each month. I think in March is the only one that it actually ends up on still the 4th Tuesday. I think there's 5 Tuesdays in that month. You can register again, and we're going to talk about a lot of different things: culture changes, communications, healthy versus unhealthy relationships. And we'll get that moving again and go more in depth on the things that we have talked about previously. So please join us for that. And I think, yeah, that is it. So we are going to turn the time over to Polly and Geoff. Like I said, you're going to see some polling questions pop up. I'm going to start the first poll in just a second and share that so Polly and Geoff know their audience and how many people are here with us today, and then we'll have the end of presentation polling at the end. So it's all you guys.
Well, good morning, everybody. Let me get this screen share going and we'll get started.
We will share the results, which is we've got, you can see 65% of the people in here are nurses, and we've got 23% EMT. And then everybody kind of sees where we are, and we'll stop sharing. You can always move it aside if you see something, a poll on there, you can move it aside or make it small.
That's what I'm struggling with. Okay.
Let's see. Hey, and there's some ski excitement for you. Polly with actual good technique. We'll see a couple other slides to determine that's a lie, but
Yeah, that's reasonable.
all right. Take it away, Polly.
All right. So we think that the first thing that you can do to prevent yourself getting injured while skiing is get fit for it. I never really thought I should get fit for skiing, but turns out I need some help in that department as I get older. The university actually offers this class. It's at the Orthopedic Center. We've included the link here. I think it's a 10-week program, right, Geoff?
Yeah, I think it's two 8-week sessions, so I think you can even go for 16 weeks.
I really think that the biggest thing you can do, the biggest favor you can do for yourself is enter the ski season being as strong as you possibly can and connected in your body. Without good quads and really a good core, you're probably going to fall a lot. We included stretching in here, I think mostly because one of our friends asked us to talk about stretching on this. I don't have anything specific to say about stretching other than one injury we do see is gastroc tears or calf tears, and some of that's ill-fitting boots, but some of it's just the fact that you are leaning forward in a position you don't normally do, and your calf muscles get really tight. They can pull, give you an Achilles injury. Those are terrible to get and take a really long time to come back from. But it's not an uncommon ski injury, which is kind of interesting. It's from falling forward, and at least in ski boots, probably not in snowboarding boots, but at least in ski boots, you fall forward and your boot doesn't give and something has to, so your gastroc or your Achilles gives. Injuries happening usually, well, it is always the last run of the day, right? Because you get injured, so it literally is the last run of the day. I was just chatting with one of our sports medicine doctors before I got on here, and Dr. Petron is his name. He was talking about the rule of thirds, which is if you were above 3,000 meters, which is roughly 9,000 feet, which is what we are up here. If it's your third day of skiing, specifically more for non-locals, right? If you're coming out, you've got a 3-day ski vacation, and it's after 3 p.m., just stop, because that is when you're going to get injured. So listen to your body. You got to know when you are getting tired. So quitting earlier rather than later will give you another day to ski rather than having your injury happen. Proper boot fitting. So having ill-fitting boots is actually a huge problem with ski injuries. It's the connection snowboard or ski boots. My experience is skiing, not snowboarding, but that connection is super important. So if they're too loose, your body will try and twist and turn in ways that your skis won't. Twisting is always a bad idea with skiing. It's generally the motion that happens right before you pop your ACL. And getting a good fitting boot can help with that. So if you don't think you need a boot fitting, you're probably wrong. Everyone can go to a boot fitter and you will see your skiing improve with that. There's several places. I get my boots fit at a place called Skimo Co. in Salt Lake. There's some place in Park City, I think. Maybe it's just called Park City Boot Fitters. I know some people have gone there. Those are the two places I know of to get your boots fit right now. I think the Deep Powder House might do it too locally up at Alta, and then at the base of the canyons as well, not Millbrooks Plaza or something. Surefoot. Okay, thanks, Allie. I don't know where Surefoot is, but anyway, it makes a huge difference. You don't think you need it. They can bake your liners. That helps with your feet. When you have a proper fitting boot, when your brain actually tells your body to make a move, you will actually do what you think you're going to do. Otherwise, you think you're telling your body to turn, and it's like delayed, and you've got this big, long, few pound object hanging off the end of your foot. So that's your ACL right there. I think that's all I have to say about this. Right, next slide, please, Geoff.
All right, perfect.
Hi, boy.
We go over just some of the basics of the responsibility code that the ski patrol has been preaching for years. Obviously, and we'll have some anecdotal pictures here. Stay in control and kind of know your skiing style. This is our, as I was researching this, I didn't realize this was a North American system only. I guess Europe does green circles, blue squares, and then orange and black circles. So that's a interesting thing. But know your skiing style. Try not to get in over your head. Try not to listen to your friends that may ski better than you to get you into places on the mountain where you can get yourself hurt. The downhill skier has the right of way. This picture is out of the East Coast, probably southern Vermont somewhere. All the New Yorkers there on the weekends. So obviously the people downhill of you can't see behind them, so it's your responsibility if you're coming up on somebody to slow down and keep a safe distance. All right. And then try to stop in a safe place. Obviously, stopping where you cannot be seen from above, downhill of a rollover or a knoll, or in the middle of a trail is always a terrible idea. Just kind of inviting injuries. Skier versus skier crashes are some of the worst things that I've been a part of as an EMS provider. I've seen some terrible things happen to people over the years with impacting another skier, whether they're stopped or they're both skiing. So it's a real danger out there. All right, and then stay out of closed areas. This is actually not a closed area, but this is me. I think natural hazards do exist. So this is a chute at Snowbird that was not quite filled in yet for the season a few years back.
Probably how it looks right now too.
Yeah, it probably looks worse than that right now. And then the last part of the skier safety code is know how to use the lifts safely. We always see a few accidents a year countrywide in people falling off the lift, whether it's not using the safety bar or just not paying that much close attention. The lift obviously it can be a mechanism for trauma, and we want to be mindful of that. All right, moving on to helmet safety. I think the biggest thing to happen in ski safety in the past 20 or 30 years, besides advances in bindings, has been helmet use. About 33% of ski injuries are head injuries, and that's decreased with helmet use over the years. Obviously, not gonna prevent every injury, but a correct fitting helmet is one way to prevent injury. I think Polly's got some stories about that from the clinic.
Thanks for the slide, Geoff.
Yeah.
So this is a patient we had here at Snowbird a couple weeks ago. He was 71. He was visiting from somewhere else. I really want to point out the fact that he was snowboarding because I think that's truly remarkable. So he fell, and that's his helmet, and he came down here. He was dizzy when he got up. He had some repetitive questioning, so patrol brought him in. We don't have a CT scan up at the Snowbird Clinic, so I mean, I think he had some like rib pain too, just general things. We sent him down to the ED because with a helmet like that, you've got to get a CT scan. He's, his right age, right mechanism. This was his helmet. So we sent him down to the ED. He actually ended up being okay. He had some incidental findings on his CT scan that prompted a follow-up with neurosurge in a couple weeks anyway. They couldn't tell if he had some chronic subdurals, and I don't know if he's just been snowboarding a lot and falling a lot. So anyway, I think his outcome was generally favorable, but that was a pretty good helmet whack. You got to replace your helmet ever so often. UV light is one of the things that breaks them down. I don't know an actual time frame for it, but I think if you ski like 100 days a year, you probably should be replacing your helmet every other year or something like that. If they get UV damage, they crack easier. So this helmet could have been old, and also why it cracked. But if he hadn't been wearing that, that would have been his head. Next slide.
This slide kind of, oh, sorry.
Helmet. No, it just says when to replace the ski helmet. Sorry, I got ahead of myself.
Oh yeah. Yeah, just after it's been in a big crash or it's got any damage on it is what this says. But I do believe you're right with every couple of years seems like a good idea.
So I gotta give, we're gonna talk about tree wells because this is a natural hazard. And I need to give some credit to Allison Conover because she talked me through this. A lot of this information is from her. So a tree well is that area around a tree that actually gathers a bunch of snow, and it doesn't get compacted by skiers because you're not skiing underneath the branches. So generally they're about as wide as the lower branches of a pine tree, and it's usually pine trees, not aspens. So the snow collects in there, never gets compacted, and it can be really light and fluffy, and sometimes can be as tall as you are, if not taller. So it is a hazard that people don't necessarily think about. If you fall near one of these tree wells, it just seems like inevitably you'll end upside down in them. And so it makes it difficult to shout for help, right? And it's hard to see you because you can be off alone, your head below the snow, or sideways in the snow. And if anyone's ever fallen in one of these, you can't get out of them. They're like quicksand. So if you're gonna ski trees, you should probably go with a friend just to keep eyes on each other and make sure you come out the other side together. If you can touch the branches of those big pine trees, you're too close. It's just like quicksand. You don't necessarily know when it's happening. The level of snow tends to be less in the early seasons. That doesn't mean that they're any less dangerous. They're still just as quicksand-like, but probably not going to be over your head. As the snowpack deepens, then the snow around the trees also deepens. These injuries are usually from lack of oxygen or asphyxiation rather than trauma. You don't need to have a lot of velocity to fall into a tree well and then not be able to get out of it. And so these people end up having respiratory arrests. There was one of these last year at Alta. It was a tele skier. He was young, and we think no one really saw it happen, but he was pulled out of a tree well. Some kids riding the lift saw him riding the lift. They skied down, finished their run, and got back on the lift, went back up there, and still saw the body in the same spot. And so they finally called patrol then, and by the time they got to him, he was actually already dead. They ended up trying to work him and coding him because he was so young and no known health problems, but he ended up passing away on the hill at Alta last year. and it was really tragic and sad. He had family up there, but he wasn't skiing with any of them. So this doesn't always just happen in the backcountry. This was a fatality that happened inbounds at Alta last year. And it was a tree well again. So be careful in the trees, basically. Next slide.
And then just we briefly touch on some backcountry safety. There's a talk coming up on this in this series on February 23rd that will go in depth on with the Utah Avalanche Center and some backcountry skiers about avalanche safety, the things you need to self-rescue, and first aid equipment. But it's something that even inbounds you should be thinking about. Our resorts aren't immune to inbounds and avalanches. I can remember about a decade ago being involved in one at Snowbird. And then, just having the tools available to you to self-rescue and give yourself any first aid that you need in the backcountry is a little bit more important when there's no patrol coming to get you. Things to bring if you're going into the backcountry: beacon, shovel, probe, your backpack to carry all these things that you need. A first aid kit, and important in that is a space blanket or some way to keep yourself warm, because hypothermia is going to be a huge factor in those types of injuries, even if it's not the main injury. Obviously, you want different layers of clothing, a way to make shelter, a way to repair your skis and bindings to get you down the hill, and maybe even some basic fire starting equipment if it's going to be a long night that you go without rescue. Talking about hypothermia and frostbite, I think every skier that I've known has all had at least that one episode of frostbite, on their face, their fingers, toes. So what you're going to look for with that, obviously white or yellow skin, waxy in appearance. Obviously those areas are going to be numb, so it might not be visible, or might not be something that the person notices. It could be one of your ski buddies says, "Hey, your face is getting a little on the white side." Obviously get to shelter if it's available to warm up that skin. You want to take some warm water and put the affected extremity into the water, not hot water, just warm, and hopefully that turns around. You also don't want to walk on it or rub your skin together. That'll cause more injury. All right, and then hypothermia, a huge problem with as a secondary injury. So say I have a knee injury and I'm laying on the mountain for 10 or 15 minutes. Generally, that's long enough to get mildly hypothermic. So things that you want to do is try to keep the patient warm, whether that's with additional blankets or things that you have with you, or kind of evacuating to an area of shelter, whether that's getting out of the wind or things like that. Obviously, hypothermia is going to be a continuum where obviously we're going to start shivering, and then eventually your mental status is going to decrease. You're going to have and then you can actually go pulseless and things. So this is one of the major factors of injury in skiing, and one of the reasons why Ski Patrol kind of wants to get you off the hill as quickly as possible in some cases to prevent some of these things. On the right side of the screen, you've got instructions for a hypothermia burrito wrap. Basically, if you have any of these things with you, kind of want a moisture barrier, warm clothing, and then kind of wrap the patient. You'll see that this kind of thing used for like toboggan transports. this slide just goes over more hypothermia stuff, the kind of the continuum. So you can kind of investigate this and read it on your own. But obviously, you want to intervene as quickly as possible, whether that's warm IV fluids, kind of depending on what we're doing. Warm IV fluids, warm shelter, blankets, all of the things, and just the necessity to keep the patient warm. All right. So this part of the presentation, we're going to kind of go through the different aspects of care, starting with the ski patrol, then going to the ski clinic, and then kind of definitive healthcare for the more severely injured trauma patient. Oh, there we go. So most of our ski patrollers here in the Wasatch are OEC certified, which is a similar certification to a EMT. They'll provide basic first aid, stabilizing injuries on scene, provide more BLS interventions, and then with the main goal to transport either off the hill or get definitive care in route, get the patient quickly off the hill to the hospital. Then we have our EMS care, our either air or BLS ambulance or ALS ambulance. So they're going to want to do all the same things. They're just thinking, you know, moving the patient again to definitive care. Let's see. Polly, you have anything to add about your interaction with EMS up at Snowbird?
Well, at Snowbird, we have a UFA station up the canyon at Little Cottonwood. So it's nice. They're stationed here for the town of Alta, and then for us. Big Cottonwood, is there an EMS crew at Big Cottonwood?
Yeah, there is. They're right below Brighton.
Yeah, you're right. Yeah. Park City obviously has a few fire guys up there that can transport, but there's just not always, they're not always readily available to transport. So sometimes that's one of the things we deal with in this type of location. If it's snowing, so you have poor visibility, we tend to see more injuries on days with worse snow conditions and low visibility. And if it's snowing, it means often that a helicopter can't fly. And if the station has already left with one trauma for the day, we have another one come in, you basically have to hang out at the clinic for a while. So it isn't always super fast to get definitive care from a ski resort, I guess I want to say. That's it.
I guess I should have switched slides before that. So, all right. And what's your capabilities at the clinic?
This is us working with that's the femur splint that Patrol has up here. It's actually really cool. It fits in this like really small little container, and then uses your own, like you leave the boot on and it uses your foot to provide traction. Like they basically just hyperflex your foot back to you. And we leave that on, so we would be delivering the patient with that in place, because traction for a femur fracture obviously is very important, but we would want it back, and I think that the UED currently has one of Patrol's femur splints probably languishing out back of the ambulance bay. No one knows what it is or why it's there. So all you cool cats and kittens at the ED, if you see one of these things that says Snowbird on it, you can give me a call. I'll come get it. Anyway, okay, next slide, please. So the most common injuries we see in ski clinics, I worked at the Alta Ski Clinic for the last 10 years, and then now this is my first year at Snowbird, but I'd say these are pretty similar, other than the fact that I never saw snowboarders at Alta, so that's been something new for me this year. Our bread and butter injuries are ACL. So the ACL is that nice bit of tissue, and I've got our here. want to show everybody. So, I don't know if you can see. No, if you're looking at the PCL. There it is. This guy right here. Not a lot. That's your ACL. But basically what it does is it keeps your femur on top of your tibia. And when you have a falling motion or a twisting motion, the femur is basically trying to slide off the tibia. And the only thing that's really keeping it there is that teensy tiny little piece of ligament. This is our most common injury by far. Maybe not with snowboarders, but with skiers for sure, because you're locked into your boot and you're always taking a twisting fall. Again, because you didn't take the university ski fitness class. And if you did, you wouldn't tear your ACL. Or if your boots are fit properly, that also really helps with it. These, I don't have the exact percentage. They almost always have to be fixed surgically. There are a few very rare people walking around out there without ACLs. But the problem you run into when you don't have the ACL holding these two bones together is you give yourself a tibial plateau fracture the next time you fall, which basically crunches your femur in the top of your tibia and you crunch off like a side. That actually has to get surgically fixed every single time, or you're looking at a knee replacement or just horrible osteoarthritis or something. The snowboarders are coming in with these radial head fractures because they're falling and then outstretching their wrists, or they fall backwards. These don't always have to be fixed surgically. We can reduce them in clinic up here actually pretty handily. We can do like what's called a hematoma block, where we just inject a bunch of lidocaine into the exact spot. We put you in those finger traps and let you hang out there for a while. Actually can kind of help reduce itself. And then you're splinted and you have to follow up with a hand guy, and they make sure basically your bones are coming back together appropriately. Shoulder dislocations, obviously that happens both skiers and snowboarders alike. The gold standard for fixing a shoulder dislocation is actually called the Snowbird technique, and it was actually developed here like a few years ago, I want to say. And it basically just involves pulling down and then like back and out on a shoulder. There are a few other techniques, like laying someone on a bed and having them dangle their arm over the side and thinking gravity will pull it back in. I've never seen that work. We are actually able, because we get these guys fresh, like you've dislocated your shoulder and I see you within 30 minutes, we usually relocate shoulders without any kind of pain medicine or dissociative medicine at all. It's pretty cool. By the time they get to an ER, it's been too long and the muscles are all seized up, and you almost always have to give these people ketamine or something stronger to help get them to relax. The key is they have to relax the muscles in their shoulder in order to relocate them. We use a sheet to hold counter traction when we do these, and then just a loop of the burn, not burn netting. The word is avoiding me right now, but evading me right now. We loop this gauze over their forearm, and then we hold counter traction with a sheet. We end up stepping in that loop to pull the shoulder down, and then it'll get back in, go around, get seated back in there. Concussion, we see a ton of concussion, especially with harder snow in the beginning of the season. I mean, concussion's on a spectrum. Of course, there's, not that big of a deal to a really big deal. Concussions can cause behavioral changes, personality changes. They can put you out of work for anywhere 4 to 6 weeks. So you really do want to actually avoid these things. Helmets is one way to do it. You can get concussed even through your helmet. So again, avoiding falling, knowing your limits, not getting, realizing I'm skiing on really icy snow right now. Like Snowbird is basically just an ice rink right now. You should bring some ice skates up here instead of skis. So we've been seeing quite a few concussions so far this season. Also, a surprising number of lacerations come into ski clinics. Ski tips, ski edges, they cut through everything. Just random, we had a lifty who was picking up a sign that was like, you know, this way in the line, and he ran his gloved hands up the side of the sign, and the fiberglass cut right through the glove and into his hand and lodged in it. So we just see a ton of lacerations up here. It's kind of interesting. So rocks, that'll cut you too. That'll make you fall and then puncture your wound and that kind of stuff. Anyway, also, if you ski with your dog, the dogs get too close to the skis and then they get cut. We sutured up a dog at Alta one day because we were a full service clinic, and it was an out of towner, and he didn't know he wasn't supposed to have his dog up there anyway, and he was on the rope tow, and the dog got close to the skis and he slit the dog's leg open. So we sutured the dog up one day. So watch your dog when you ski with them. Okay, boot removal. We're very proud of our boot removal ability here at the Snowbird Ski Clinic. This is so true that many hands make light work. Don't try and take a boot off by yourself. It's not gonna go well. So you need a minimum of 3 people. Consider first warming the boot up with a hair dryer. When it's cold, the boots are going to be stiff and it's going to be a lot harder. So envision this floppy tip fib and the boot's still attached. We recommend wearing gloves because you don't know if it's open. We've all like gone in to stabilize on a leg and then pulled a hand out and it's covered in blood because it's actually an open tip fib in there and it's all just draining into the boot. So you don't know it. So first things first, warm your boot, put on gloves, and then you need 3 people. One role is stabilizing the bone above. So really getting your whole forearms, your hands, everything around that leg, and you're holding like pretty tight pressure on that leg. You need a spreader, so that's someone that has taken the buckles of the boot and they're spreading them apart. Again, it's helpful when it's warm there. And then you have one person that's pulling. I like to seat the end of the boot into my shoulder, and I use a scooping motion, and I tell the patient to point their toe. Even if they have a floppy tip fib, they can always point their toe. When they do that, that helps the boot get around the heel and it comes up and off. Sometimes it's just painful. So if it's really looking bad, I consider giving them ketamine before we take it off. We have the advantage of rolling them directly over to our x-ray. We'll get an x-ray through the boot. It's a nasty looking x-ray because you've got all the metal and the buckles and stuff like that, but you can at least see what you're dealing with. And that's super helpful for us. So we'll get a through the boot x-ray, and if it looks bad, it just smashed, we'll suggest something like ketamine or at least a hefty dose of fentanyl, like 100 to 200 mics, before we pull the boot off. That's it. Once you get the boot off, you re-x-ray it to get a better look at it, and then you splint and send them to definitive care because they'll need to have it operated on.
Obviously, ski helmets are much easier to remove than most of those other types of full face helmets. But I just wanted to go over the process of doing that in case you were with a patient that needed that. You want to undo the chin strap, obviously, and then you're going to need 2 people. One person's going to hold C-spine from the angle of the foot, I guess, and then the other person's gonna rotate the helmet so like the forehead comes down into the face, and that'll get the helmet off the back occiput of the head, and then you should be able to come straight off. Obviously, if the patient has a full face helmet for skiing, it's a little bit more difficult, but same technique for all of these helmets that you would encounter on the hill. Shameless powder skiing photo there. All right, and what was that?
Sure, that was Snowbird.
No, I think it was in the backcountry. So, yeah, you never get untracked powder at Snowbird. So, as far as your decisions to get helicopter EMS going, these patients are going to be your more traumatically injured with high mechanism of injury that you suspect big things, either a big head injury with a decreasing GCS, chest and abdominal injuries, pelvic injuries, and things like that. Just quickly go over some landing zone criteria for the folks that would be involved in calling AirMed or Life Flight. Just looking at your landing zone stuff. You want to look for obstacles, obviously, overhead obstacles, poles, wires, big pine trees, and things like that. Try to get a GPS coordinate if you can. Most cell phones have those in your Compass app. That helps us because we might not know where we're going. It's kind of hard to see from the air. Surface conditions. So if there's a ton of new snow and you have enough people, maybe pack down the area. That helps with whiteout conditions. And then we'll talk about the helicopter always kind of wants to land upwind if possible. So try to figure out which way the wind's coming. That'll kind of tell you where you think we'll be coming from. Hopefully we'll be in radio communication on either one of your patrol frequencies or LZ1. And then the big thing about helicopters in ski areas, they attract attention, obviously. So you want to have people ready to do some crowd control, make sure the landing zone remains safe. And then the thing that is the biggest thing is a tail rotor guard. The rotor on the back of the helicopter is what really can hurt people. So we want somebody watching that at all times, making sure there's nobody approaching it. The other thing you have to think about is slope angle. So if the helicopter is forced to land on a slope, such as a ski hill, the uphill side the rotor system is going to be a little bit closer to the ground. So you're going to want to not move around the helicopter on that side of it. So also don't approach the helicopter without one of the crew members being with you. So never go under the rotor system without a helicopter crew member with you. Will come out to you. All right, and this is just an example of a landing zone, and they've popped smoke, and so this tells us where you want us, and kind of tells us the wind conditions on the ground, which can be vastly different from circling overhead. All right, another shot of Polly, slaying it. Free the heel, free the mind.
So free right there. Not in the back seat. So good.
Does anybody have any questions? I think that does it.
Yeah, I think that's great. Like Polly, I said, every picture I see of you makes me think that I ended up in the ER if I tried these things. I'm really good at falling and skiing. Really good at it. Snowboarding I tried, and I fell off the lift every single time I tried snowboarding. So I just gave up on anything but snowshoeing at all, or hiking. I did have a question for both of you to kind of talk about. We've seen a lot of people, obviously, that leave the mountain and they've had an injury, but they don't get seen at the clinic. They don't get seen by ski patrol. Most of us as healthcare workers are going to be able to see those warning signs, but just talking about maybe the warning signs people need to look at, and injuries that you would normally see that bring people back to be checked out in the hospital at a later time once they come off the mountain.
I would think concussions are the thing that you worry about the most, and more significant head injuries. So monitoring your friends that have maybe suffered a concussion, monitoring them for 24 hours. I think the advice of not letting someone sleep is gone, but keeping an eye on those folks, making sure they're not deteriorating is the most pressing injury I can think of.
I had a late 60s gentleman here this year at the Snowbird Clinic who came in because he fell, and he was repetitive questioning. He was also completely drunk. So that kind of patient, he was drinking schnapps, I think, from a flask. It was amazing. And he didn't want to be seen. His daughter brought him in and he didn't want to be seen. And I was like, dude, you have to go down and get seen. Like, I can't tell you that you're fine. You're drunk. You're saying the same thing over and over again. You don't even remember falling, but your daughter saw it. We told him to go down. He did not. I know, because I called the ER and he never showed up. So that's concerning, right? I can't tell if you're just drunk. And it's common for people to drink and ski. They're having a good time, they're on vacation. I have to err on the side of being cautious in that situation, because no healthcare provider can tell you that you're totally fine and you're just drunk. You could certainly have some sort of slow bleed happening in there, or even just, a little brain bruise, whatever. That should be followed closely and should have, you should probably stop taking your aspirin, but I need to know that to tell you that. So people don't want to get seen either for their knees, and that's not life-threatening. But if your knee swells up significantly after you've had a twisting fall and you don't want to get seen right away, that's fine, but you do need to go in and get seen eventually. You could just have like an effusion or something. You could have an MCL sprain, which isn't surgical at all. Even tearing your MCL isn't necessarily surgical. You can oftentimes damage the meniscus in your knee and it will bother you for the next 10 years and you will eventually get surgery on it. Swelling's a good sign that you did something traumatic enough to require intervention. You can always go home and do the RICE thing, right? The rest, ice, compression, elevation, and see if it gets better. We give everyone, like, you walk in the clinic and you get 600 of ibuprofen basically all day. That's our first go-to. So it's a good medicine. You can take that at home too, but you should probably get it seen by a sports medicine doctor if you have swelling in any part of your body after a ski fall.
Awesome. What about, and how often do you guys see elevation sickness or people that are struggling with what they call the cold dehydration? Because we all know when we're cold, we're not drinking. And I mean, unless they're drinking beer or schnapps, because I've had a trauma come in and we emptied out his couple beers out of his snowsuit and then started taking care of him.
Yes.
How often do you guys kind of see that?
Altitude illness is not a significant portion of what we see here, but so Hidden Peak's 11,000 feet. That's the tallest peak accessed by either Alta or Snowbird. The base of Alta is 8,400, and really they say you got to get below 8,000 feet to start healing from altitude illness. You can't, your body can't handle it until you get below 8. So I don't know. It happens with people that leave New York, get on an airplane, fly to Salt Lake, get in their rental car, and drive up to Alta and stay the night. They start feeling poorly sometime during that night. And then they show up at the clinic the next day. Their stats are like, I don't know, maybe 90%. They're not crazy, but 90's borderline, obviously. We will treat them with dexamethasone or acetazolamide, and then we can rent them like an oxygen concentrator to help them at night. That usually helps people out a ton, and then we just push fluids. Altitude illness affects people regardless of fitness, age, experience. One time you can go to 14,000 feet and be fine, and the next time you can go and be altered, vomiting, experiencing significant symptoms. And there's no rhyme or reason to it. And really, dexamethasone and acetazolamide don't necessarily fix it. They can just kind of help with it. You have to descend below 8,000 feet to fix it. I have never seen HAPE here. I don't think we're high enough for it. You probably have to be, I don't know, somewhere in Europe or Himalayas or something like that to get high enough for that. I don't think you'd see it in the lower 48. So I'd say less than 10% of my patients have that. I haven't seen anyone with it this year at Snowbird. We've had fewer tourists though, fewer people. We've had a lot more Californians than East Coasters this year, I think, just because of COVID and traveling. So I haven't given any of those medicines yet. Acetazolamide is Diamox. It actually works on your pulmonary system. It's a little bit of a diuretic, helps you fluid shift, supposed to help you breathe a little better. It's the gold standard medicine for Himalayan high altitude illness. Like that'll be in everyone's kit. I think it's in a few movies too. hit him with the Diamox. Oh yeah, Crested Buttes. Tall though. Colorado resorts are taller. They just higher elevation. We're just not that high here. He's the greatest snow though.
All right, I'm going to open it up to everybody and see if you guys have any questions for Polly and Geoff.
Snowbird's the greatest clinic ever of all time. I'll just plug that right here, shamelessly.
I like that. I mean, you know, Utah's the greatest snow on earth, right? That's what they say. And I'll go snowshoeing in it all day long, but nothing else.
I really like what we have here too with the U being up here now, because if you get in and get seen here, A, we really don't have wait times, and B, we'll set you up with your clinic appointment right away and get you in. So I think it's awesome patient care that we can provide here for people. Get your initial assessment done and then get in and we'll get you into the right surgeon or whatever. We've got inlines with all of them. So I think we're doing a good thing for the community up here.
And hopefully you never get to see Geoff on the helicopter. You only see him passing you on the slopes. Something like that, other than picking you up.
Safely passing.
Yeah.
So I want to say at this point in our season, Snow Basin or Powder Mountain, I think one of them has had a fatality. We've had a fatality, and Alta has had a head injury, like a severe head injury patient that I think is still in the NCC at the U, I think.
And I believe Park City, sorry, you can hear my dogs in the background. Park City, I think, has also had a fatality and a couple pretty severe injuries as well from skiing.
It's been a year for sure. So AirMed's already landed here once. I think AirMed landed up on that Alta one too. I don't know about Brighton or Solitude, but they've already been here.
Yeah, unfortunately, I've had a lot more resort calls this year. I think we just need some more snow.
Yeah.
That seems to be the overriding factor, at least to me.
It's icy. It's so icy out there. Anyway, thanks you guys for letting us share. Sorry if none of this information was completely mind-blowing, but
yes, I agree. It is great when we have snow.
all the dogs.
My dogs are going crazy.
Your contact hour, if you filled out all of the polls, we'll get your contact hour certificate out to you. And if you have any other questions, please email Jamie Troyer or myself, Emily Johnson, and we'll get those questions to Geoff and Polly. And Geoff and Polly, thank you so much again for this great presentation. We really appreciate you. Bye.
Thanks for having us.
Thanks, everyone.